what I will show you right now is the scoring sheet that I've updated. Again, this is not a official scoring sheet because there is no official scoring sheet. But to kind of take you through what we're seeing here, we've got the trial numbers of our swallowing protocol, and I've divided this into kind of two portions. This is what I recommend people do clinically, is having some sort of pretty standardized controlled portion so that we can compare the patient to themselves over time and to other patients and hopefully to healthy adults if and when we have that data. And then also something that's a little bit more functional for the patient specifically. So I don't have anything here specifically because it'll just depend on the person based off of what they're currently eating and drinking and maybe any sort of specific complaints that they have. So the first thing that we'd always want to do is look at their secretions. And this is kind of an example of a standardized protocol that I would probably do clinically. And it might depend on the clinical setting that you're in. So, you know, if you're acute inpatient, you're working with people who just had a lung transplant, you might not start off with a normal sip. You might want to be quote unquote conservative and start off with something pretty small. People don't always do better with small sips, but the consequence of them aspirating this might be a little bit less prominent than if they aspirated something much greater. Some people do much better with 20 and they actually aspirate less, but the amount of potential aspirate material is actually, you know, less if it's a smaller sip. So, so this is just one example of a potential standardized protocol. So you'll see that we have our different secretions, our different consistencies here. So IDSI is an International Dysphagia Diet Standard Initiative. And so we have consistencies that range from 0 to 7, 0 being thin liquid. This is just slightly thick. I think this is supposed to represent like breast milk. So it's really kind of more for NICU. And then 2 is mildly thick, moderately thick. And then we start to get to like puree, or maybe 5 is puree, I forgot. And if you forget, you can go to this note, this coding section where I put the IDSI framework. So a 4 would be extremely thick liquid, which consists with puree. 3 is liquidized liquid, which overlaps with moderately thick liquid. And we move up the minced moist, soft white, and regular. So we have these consistencies. Then we have a mix. So this might be something like the pineapple with pineapple juice, which technically would be like a 0 and maybe a 6 together, but we'll just say mixed. And then secretions. We have our bolus delivery method. So we have a variety of different options here. The reason why I made these drop downs is so that we just make sure we don't have any errors in data entry. So if there's any changes that you'd like, just, you know, let me know. So the things about the mix and stuff that helped. Most of the times things are going to be self-administered in our protocols, but again, this might depend on our patient population and the setting that we're in. So most of our patients are ambulatory, so things would be self-administered. But, you know, we work with lots of people who do have movement disorders, and so maybe they might need assistance getting the food to their mouth. So you might have not self-administered, or you might have had something like assisted, actually. Certainly if they're inpatient and they're like lying in a bed, someone might be feeding them. So, but all of our stuff would be self-administered. As previously mentioned, we have held and non-cued, and I have these in this note section here. So held, non-held, this refers to an instruction given before the swallow, where we might ask someone to take a sip, hold it in your mouth, breathe normally for a few seconds, and then swallow whenever you're ready. This, I believe, is done in MBS-INP. We oftentimes do this with feeds when we're trying to get an idea of oral bolus control. If we ask someone to hold something in their mouth, can they do it? Or are we getting movement of bolus into the pharynx? We have a cued swallow. So this doesn't necessarily mean an instructed swallow. This means that it's held, and then we are saying, wait for us, and then we'll tell you when to swallow. So something like hold, hold, hold. Okay, go ahead and swallow. So there it's cued in addition to being held. Held would just be take a sip, hold it, then you swallow whenever you're ready. Go ahead. And then kind of like do their thing. Hopefully they hold it, and then hopefully they swallow in a few seconds. Swallow instruction, this refers to and these are not agreed upon terms, so that's why I have this in the notes section. So natural would just be take a sip, drink it like you normally would, versus something like a single swallow. So I want you to take the sip, take the whole thing, take all 10 or all 15 or all 20 milliliters, and do it in one swallow as best as you can. And then we have our different colorants. And as we mentioned the other day, a coating liquid is going to be also opaque. I can't imagine a situation where it wouldn't be. But just because something is opaque doesn't mean it has like this pretty vibrant kind of coating effect. So, so for white, we have white, which is opaque. So this could be something like milk. What we do here is we do water with a couple drops of white dye to make it opaque. And then to make it coating, we do water with a lot of white dye. So we do about 10 milliliters of white dye for every 165 milliliters of water. Could use barium potentially. We've moved away from that. Blue translucent, this would be blue water that's been dyed with a little bit of blue food coloring. Blue opaque would be blue water with a couple drops of white dye. Blue coating would be blue water with a lot of white dye. Although in my experience, trying to make this coating actually very blue is pretty difficult. It still kind of shows up as pretty white on endoscopy when there's light shining on it. So oftentimes what you'll see here, this is kind of what I would do clinically and what I'm doing for this research, is rotating between white coating and then blue opaque, and then white coating and then blue opaque. If you're doing 3 trials of everything, which I've done in the past, you might do white coating, blue opaque, green opaque. And in fact, the way I actually did it, the order for me did matter. So I would do green opaque, white coating, blue opaque, so that I'm separating the green and the blue opaques because they can still kind of look a little similar. So I would kind of separate the things that could look similar as much as you can, because that's going to help ease your fees interpretation. But yeah, so I'm just kind of now switching to 2 trials of each. I love the idea of doing 3 trials of each, but there's a lot I want to try to look at, so I'm trying to parse it down. And then when we move over a little bit more on this rating sheet, then we get to the actual residue ratings. I'm going to go back here. So in terms of the scoring sheet, you will probably develop, I mean, here, this is the protocol that I've developed for what I'm doing right now, but depending on the setting that you're in or where you move to later, you'll have your own protocol, hopefully, that you develop. And so this, you'll kind of adjust for your own protocol, and then you won't have to kind of keep typing this in after every single time, right? So, so understand that that'll be filled in, and then really all you're doing is kind of filling in these outcome measures. So we have our VASES residue ratings. These scores should range from 0 to 100, except for the vocal folds and subglottis, which could technically go above 100. And then we have our PAS ratings before, during, after, and between. So providing a PAS for each of these. So this would be a drop down ranging from 1 to 8 for the PAS scale. And then the max PAS gets calculated off of the worst PAS. And so what we're doing now with VASES is providing a PAS rating for each temporal marker. And if there's a change in bolus flow from one temporal boundary or timing group to another timing group, then we do a change in PAS. So let's say someone had no air invasion before the swallow. That'd be a PAS of 1. Let's say they had a PAS of 5 during the swallow. And then, so this is residue on the vocal folds, and then nothing changed after. So we still see that there's just residue on the vocal folds and nothing's happening. They don't cough or anything. And then this would be a PAS of 1. And then between bolus trials, PAS of 1 if nothing has changed. If, let's say, we saw that they had residue on the vocal folds during the swallow, meaning that probably at the onset of after the swallow is when we're seeing something and there's not much change, then this would be a PAS of 5. But then if eventually stuff trickles down into the subglottis, it's the same residue from this swallow, but it trickles down to the subglottis, then we still keep the PIS of 5 for during, but now after the swallow is when we're seeing it, the bolus flow to a new location. They don't cough, then we would call this an 8. And then we might keep this the same if there's no change. But if we wait 5 seconds, we get to the between bolus trial phase, and then they cough in response to the stuff that was there from after the swallow, then we might give this a 7. If they don't cough and there's no change in bolus flow, then this would be a 1. So what we're really trying to capture is changes in bolus flow or reaction. Another example might be 1s across the board, like there was no airway invasion, but there was a lot of pharyngeal residue and maybe in the hypopharynx. So then maybe during between bolus trials, the stuff that was in the hypopharynx then spilled in afterwards and caused, let's say, silent aspiration. So that could be something like that too. So a change in bolus flow from one location to another, or a cough response from one temporal boundary to another. But if there's no change in bolus flow or reaction, and we just have, let's say, residue in the vestibule across all boundaries, we're not going to give them a 3 across all boundaries. It would be a 3, 1, 1, 1, or wherever that 3 occurred. And then the max PAS gets automatically calculated. And then the other things that we're looking at are bolus location at swallow onset. So this would be at the onset of during the swallow phase, right here. So the onset of laryngeal and pharyngeal elevation that's uninterrupted and leads to the swallow. Where is the bolus? So do we not see it? Then we would call that the oral cavity. If we see it, then we are using our anatomic boundaries to try to estimate where. It's important to note that we could be off with this, right? We could not see it because the velum is hitting the camera and that could obscure something. So this is, of course, going to influence where your camera is and how you're performing the fees. We want to be standardized about that. And then we want to try to estimate, and of course, we could miss certain swallows. This might not be 100% accurate, but we want to estimate the number of swallows that's occurring during the swallow. So this is going to be especially important for patient-preferred volumes. Patient-preferred volumes, natural, where we're like, just take this and drink it like you normally would. It's functional. We'll give someone a sip, take a normal size sip, drink it like you normally would. And for us, it would be helpful to know, oh yeah, what's functional for them is when they take a single sip, it takes them 4 swallows to swallow something down. They do a great job. There's no airway invasion, there's no residue, but we probably want to document the fact that it took them 4 swallows. And so that's what we are doing here. And then in the additional notes section, you can write additional notes. So things like if it's the patient preferred volume, you might track their sip size here. What's their sip size for that swallow, which I highly recommend doing. Something I've been asked before, and I think that you all asked recently, is let's say we see aspiration, we see subglottic residue, but it's not from the bolus that was given just now, it's from a previous bolus and we didn't see it from the previous trial. What do we do? Well, that would be an example where you might put it in the additional notes, because we wouldn't go back and change our PAS ratings or our VASES residue ratings. We rate what we see for that video clip. But then we might say, but, subglottic residue, aspiration not seen on this video clip and was not rated, but was seen in 2 video clips from now or something, or in 2 trials later. So you might do something like that to document what you're seeing. So that's the scoring sheet. Again, if you have any questions, you can go to the notes section to look at all of this, and then to get an idea of kind of what our options are. This is not something you can change. I've locked this, but this will be here for reference. And then something that you might consider doing is ultimately providing digest ratings. So VASES is used at the swallow by swallow level. And then something that I recommend doing is using these ratings to ultimately derive like a more global measure of their dysphagia. So as clinicians, we really like to say someone has mild dysphagia, they have moderate dysphagia, they have severe dysphagia. And that's what digest and digest fees. So there's digest, which is what originally published for fluoro, and then digest fees is really helpful for doing. It takes into account a complete standardized protocol, and it looks at impairments in swallowing safety, so penetration and aspiration, and also swallowing efficiency, so pharyngeal residue. And you can see here that when we look at, so we can get 3 scores, or 3 what we call grades with digest fees. We get a safety grade, so they've got moderate impairment with safety, mild impairment with safety, maximal impairment with safety. We have efficiency grades. So again, mild, moderate, severe, or life-threatening grades. And then from there, we can get a total score. So a combined score of both their swallowing safety and efficiency. And that's what this little table is here. So if someone has a safety score of 0, which would be no impairment in safety, and an efficiency score of 0, you would look and identify the cell that's associated with both of those. So they would have no dysphagia. If someone has maybe severe dysphagia and no problems with swallowing efficiency, you would look for that and be like, oh, they've got severe overall dysphagia. If they have a safety score of 2 or safety grade of 2, and then maybe an efficiency grade of 3, you would look there and be like, oh, they've got severe dysphagia. So you'd use this table to provide an overall. So if I was writing maybe my fees report and my impressions, I would say patient presents with moderate oral pharyngeal dysphagia characterized by maybe mild impairments in swallowing safety and moderate impairments in swallowing efficiency. And this would be based off of our standardized protocol. And this is how you would determine what the different grades are. So if we wanted to look at a safety grades, we look at the maximal PIS score across all Bolus trials. And follow their instructions here. And you're looking at kind of the frequency of that maximal score. So is it single, is it intermittent or chronic? And then also a little bit regarding the amount. So is it a gross amount or not? So it's kind of taking into account the frequency and the severity of the worst PAS, essentially. And so to define what intermittent is, they have that here. So it's on multiple but less than 50% of trials of a single consistency, or chronic would be greater than or equal to 50% of liquid trials, and or on more than one consistency. And so that's why in the protocol that I'm doing, it's got liquids plus a pudding plus a cracker. So we're kind of getting multiple consistencies in there. And then in terms of the amount, we have trace, neither trace nor gross, or gross, which is greater than 25%. And so here, this is where I'm not quite sure how it lines up exactly with VASES, because this is about bolus volume, and what we're talking about is how full is an anatomic space, or how much covering is present in an anatomic space. But I would use our VASES ratings here. So if we're talking about aspiration, it's I would think about is greater than 25% of the subglottic shelf covered with residue. So you would just look at what your previous rating was, right, for that swallow. Yes, and yeah, and I guess that's really, when we think about gross, it's really just for, it looks for like aspiration. It looks like it's just for aspiration that we are concerned about grossness. So you're really kind of thinking about subglottic shelf surface area for that. And then efficiency, we have our own kind of rules here that I'll let you look at. But what we're seeing, again, is kind of 10%. So what I do for efficiency is average together the oral and hypopharynx residue to get an overall pharyngeal residue score. So then when I average together the oral and the hypopharynx, then we would get a single, pharyngeal score, and we would say, is it less than 10%? Is it 10 to 33%? All right, so if we had an oropharynx score of let's say 30, and then a hypopharynx score of 10, then the pharyngeal score would be 20. And we say, oh, for that bolus, pharyngeal residue was 20, which would be in this category. Oh, it was of a, let's say liquid, then they have a grade of 1. And then we would just kind of follow this flow sheet to determine that.
Like a standardized way, rather than being like, oh, it seems not.
Yeah. So so in terms of clinical practice, Digest was originally published by Dr. Kate Hutchison at MD Anderson, I believe in 2017. And she does a lot of work with people with head and neck cancer. And so I believe the motivation for the development was that she does lots of kind of larger studies, and when doing clinical trials in people with head and neck cancer, there are these different like grades of toxicity associated with radiation therapy. I'm not sure if they also associate that with surgical interventions or not. And they needed a way for swallowing outcomes to kind of fit within some head and neck cancer kind of clinical outcomes. And so that's why Digest, I believe, stands for Dynamic Imaging Grade of Swallowing Toxicity. It's kind of related to some of that background. But so they're originally developed in head and neck cancer for video fluoroscopy. And since then has been validated, I think, just in ALS, and maybe looks like there's going to be an ASHA presentation on it in Parkinson's disease by Mehak Narani, who is alum here. And then Heather Starmer, who does a lot of work with head and neck cancer, she's at Stanford University in California, worked with Kate and a team of people and extended this to FEES, again, for head and neck cancer. Now, does this need to be validated across different patient populations? I personally don't think so. I don't think it makes sense. I mean, I think we are talking about a standardized approach to analyze something. So why doesn't it apply across patient populations? So I think you could use this clinically for anybody. I think the implications of what a mild dysphagia or a moderate dysphagia or severe dysphagia or life-threatening dysphagia, I think that probably varies across patient populations, right? So people with head and neck cancer, maybe they can kind of withstand a lot more. So by the time they get here, this is life-threatening, but a mild dysphagia for someone else could actually be life-threatening if they've got bilateral lung transplant or something like that. So I kind of use these terms with a little bit of, you want to lay your clinical impressions on top of that. This person presents with a mild oropharyngeal dysphagia characterized by mild impairments in both swallowing safety and efficiency. This does not appear to present kind of high risk for medical complications for this patient, or this appears to present with very high risk for medical complications for this patient, right? So you would kind of maybe layer your impressions or consult with a physician on top of that. But the advantage is, well, you said mild dysphagia. I have an idea of what mild dysphagia looks like because these are our different options. I have an idea of what a mild swallowing safety impairment looks like. I have an idea of what mild swallowing efficiency looks like, given your protocol, right? So that's the other thing, is they recommend that everyone kind of uses the same protocol, but at the very least, being standardized at your own institution. And to me, that actually makes more sense. I think having a standardized protocol across all patient populations doesn't make the most sense. I think there should be some flexibility. So I would outline what your standardized protocol is, and then within that context, rate Digest. And so that's what we have here, right? So that's why when we go back to this protocol for right now, the Digest rating is done after the standardized portion of the swallowing protocol, and then you move on to the non-standardized portion. And then, of course, in the scoring sheet, I'm also making note of if we use any sort of nasal anesthetics, vasoconstrictors, or lubrication gel, because all those things can affect functional swallowing outcomes. And so if we are seeing someone and tracking changes over time, we maybe saw them pre and post therapy, or they've got a degenerative disease, we see them a year later, we want to know, this exam had topical nasal anesthetics. This one didn't. That could explain why there's maybe a little bit of a difference. I'm not 100% certain. We just know what factors are potentially playing a role in what we're seeing. So again, just trying to be standardized and transparent in terms of what we're doing. Okay, so questions about this scoring sheet, digest, VASES, anything about that? Okay. All right, so then let's review the anatomic boundaries quickly, just as a refresher. Okay, so if you look at this image again, what we're thinking about, we have 6 anatomic boundaries defined by VASES. What are they? Yep.
The hypopharynx.
Hypopharynx, yep.
Epiglottis,
Yep.
vestibule,
Vestibule,
propofol,
yep.
subglottis.
Great. Okay, good. So how do we create the boundary between the oropharynx and the hypopharynx? What do we do?
Oh. Okay, it's those little like dots. You put the dots where those two, I'm gonna use the wrong word, like cartilages.
Yeah, wrong word, but I like where you're going with things. Okay, this is good.
Where they meet,
Yep,
and then it's a cross.
great. Can someone refine what she said?
It's at the edge of the epiglottis, and where the epiglottis and vestibule meet, and then to the base of tongue, you just go like outward.
Okay, yeah, that was better. That was better. These are all great.
Are you looking for the words area of the body folds?
Those are great words. Yep.
So it's weird. We're taking a step higher every time.
Yeah, exactly.
So those meet the epiglottis.
Yeah,
point.
so we're looking at the points or dots where the area epiglottic folds merge into the epiglottis. Okay, and so what I look at is oftentimes we'll have kind of like this dark shadow. And so I look for that, kind of tracing that forward, and I look to see when does it merge into the epiglottis. So either when do I kind of no longer see the shadow, or there doesn't have to be a shadow there. So when do we no longer get kind of like this medial edge to it? Oftentimes there is a shadow. So I actually look to see when does this shadow kind of trifurcate. So here's a single line, and then I kind of see a shadow there and a shadow there. So it's like do we have like it looks like a Y, an upside down Y, or like a peace sign, like we're hippies or something from the 60s, right? So that's what it kind of looks like. Same thing over here, right? So we have kind of a shadow, but also it's like kind of loose, but maybe there's like a little trifurcation. Otherwise, we just kind of lose like a clear lower lip. So we find these 2 points where the epiglottic folds emerge in the epiglottis, or these 2 dots. And then we draw an imaginary line across the monitor. Okay, so these are our 2 dots. This could actually be moved over here a little bit more. This could be moved over here a little bit more. Draw the imaginary line, and then everything above it would be the oropharynx. Now, this is mentioned, I believe, in the manuscript. I was talking about this a little bit yesterday. You want to conceptualize that this line is at a vertical height, and it should be extended laterally and posteriorly along the posterior pharyngeal wall. Okay, so so this could kind of like wrap around here. And so maybe like some of this tissue up here is part of the oropharynx. Maybe some of this is part of the oropharynx too. Okay. So that I think is a little bit harder to conceptualize and probably a little bit less impactful, honestly. It probably won't affect our ratings that much, but just to kind of have that conceptualization in your head, right? This is kind of a cylinder. We're looking down at the cylinder and we're thinking about the vertical height at which this boundary ends. And so it's at this level, we'd wrap this around. So this would be the oropharynx. And then contained within the oropharynx, we have the vallecula. So that's that 3-dimensional space extending from the rim of the epiglottis. We define the rim as the point where the laryngeal and lingual surfaces meet. So the lingual surface would be kind of the back end or the anterior aspect of the epiglottis. And then the laryngeal surface would be the portion that's facing the larynx. And so this kind of front end, or really actually posterior end, would be the laryngeal surface. So these 2 points is how we define the rim of the epiglottis. Some people define the rim as kind of like the topmost point of the epiglottis, but that can kind of change based on the viewpoint. And so that's how we define this. So the vallecula would extend from that rim horizontally straight across to the base of tongue. So here we have these folds of tissue which aren't part of the base of the tongue, but they kind of provide the nice kind of lateral aspects of it. So don't include that, but then we go straight across to the base of tongue, staying at this same height and just going perpendicular to the base of tongue. That's our vallecula. So then when we rate oropharyngeal residue, we ask ourselves the question of how full is the vallecula with oropharyngeal residue? How full is this three-dimensional space with oropharyngeal residue? So how full is this area with all the residue seen in this blue shaded region? For liquids, most of the time it'll settle in the vallecula anyway. But if it's pudding or cracker, it could be kind of stuck on these little folds, or kind of higher up in the base of the tongue, or maybe kind of higher up on the posterior pharyngeal wall. And so if that was the case, then we would pretend to scoop it all and put it in the vallecula. Furthermore, we want to try to think about the vallecula. We want to try to conceptualize what would the vallecula look like at its kind of largest space, like we see here. If the person is talking, or maybe they're nervous or something, maybe their base of tongue is going to kind of retract a little bit and abut the epiglottis, in which case the vallecular space is super small. And we don't want to judge residue then, because then a small drop is going to look like maximal filling up of the vallecula. So we want to try to get an image of the vallecula at its largest. And if we don't, we want to kind of make a best guess of what that looks like. And that might be from before we even give them foods and liquids, when we're doing maybe some of our pre-swallowing pharyngo-laryngoscopic tasks. Then to draw the boundary for the hypopharynx, it's the same boundary you all just said. So it's the 2 points, draw the imaginary line, and now everything behind it and inferior would be the hypopharynx. If I could adjust this figure, I would. What would be the thing I would fix about this figure?
Maybe move it, like past the arytenoids would be not included in the hypopharynx.
The arytenoids would be included in the hypopharynx. This is actually a pretty good boundary. I would not change this. I like this. I'm thinking more actually kind of this pharyngeal wall area. I think some of this higher up is actually probably the oropharynx. So kind of like where this date kind of area is, I'd probably have that as the oropharynx, not the hypopharynx. Right, because we're kind of thinking about what is this kind of vertical level. Again, probably not a huge deal in terms of overall ratings, because we're probably always going to have a little bit of something on the pharyngeal walls, both oro and hypo. So, I'm not actually overly concerned with this. I just want you to have that specificity in your head. But what you will notice is that when we make this tracing, and this is kind of getting at what you're talking about with regards to the arytenoids, we are looking at the medial superiormost point of the epiglottic folds and the arytenoids. So we are essentially taking this shadow, tracing this around, shadow, tracing this around, and connecting these points, not including the interarytenoid tissue, and everything above it or lateral to it would be kind of that boundary for the hypopharynx. So the arytenoids are included within the hypopharynx. And then the piriforms would be going straight across the posterior pharyngeal wall. So it's that three-dimensional kind kind of U-shaped cavity. So then we ask ourselves for this, how full are the piriforms with hypopharyngeal residue? How much filling up of this three-dimensional space, both the left and both their right and their left together. Again, if it's liquids, it'll probably just pool here. If it's not, it might be stuck on other parts of the pharyngeal wall. And like the vallecula, we want to judge this when it appears its largest. So this would not be an ideal view for when we actually judge hypopharyngeal residue. Ideally, the vocal folds would be at least partially adducted because they are exhaling air, or maybe because they are phonating or something, right? Because if the vocal folds adduct together to midline, then we're going to have an enlargement of the piriform sinuses. So we're conceptualizing when the piriforms kind of look their largest, then judging how full are the piriforms with hypopharyngeal residue. So that's that boundaries. How do we do the boundary for the epiglottis?
Where the vestibule, like the area of the bladder folds meet the
Nice. Okay, great. Okay, yeah, so that's where we can improve that a little bit more. So the first part was great. So the epiglottic folds merge with the epiglottis. Love that. So that's kind of these 2 points.
Yeah, below it's like where that shadow, if you can see under like the darker line is where it would end.
The shadow. So which
Like the other side.
wait, the patient's left or right?
No, I was more saying like go down.
Like
a little.
anterior.
Anterior.
Oh, okay, like here-ish.
Like the petioles space.
Oh, up here?
No. I was more saying like the shadow underneath that goes like into the to the vallecula is like where the anterior boundary would be.
Oh, of the
I mean,
epiglottis.
yeah. Isn't that what you asked? The epiglottis? Or is it up?
Yeah. Oh, so you're saying like up here. Oh, you're saying like this boundary. Okay, I see what you're saying. I see what you're saying. I see what you're saying.
And then you go around.
And then you go around. I see. How do you define like so let's call this the superior boundary of the epiglottis. How do you define the inferior boundary of the epiglottis? So we have like lateral here, we have superior, and then as we go down, it's inferior. So how do we kind of judge like, where does it end in this region? It's kind of where two structures meet. So it's the free end of the epiglottis and the epiglottic petiole. So if we were to look here, it's kind of, this is kind of what I'm talking about right now. So we have where the epiglottic folds merge in the epiglottis. We have this little mound of tissue here called the epiglottic petiole. And then we have the floppy part. So in video floral, that's the part that actually goes retroflexed and then completely retroflexed. So there should be a little valley between the petiole and the free end of the epiglottis. And so you want to think about the middle, we want to think about the deepest part of that valley, which would be the middle of it, essentially. This is a very bright view. Normally we get like a shadow, so it might be like the middle of the shadow. So what I do when I'm thinking about this boundary is I do identify the points where the epiglottic folds merge in the epiglottis again. And then my eye goes to this region, the center region, and I say, where's the middlemost point? Here-ish. And then I try to trace that around and then kind of make the leap to the epiglottic folds. It's always a little scary and might not always be 100% right. But I'm like here, and I'm like, I guess I'll just kind of trace the shadows, probably what I end up doing. And there we have it. And then we would trace that around the rim of the epiglottis, just like you were saying, exactly. I think this part tends to be the hardest part here. So then this would all be the epiglottis. Again, just like all the other boundaries, everything has to be crossing it in order to be moving on to the next boundary. It can't just be touching it. So if it's on this dashed line, if residue is on the dashed line, then residue is considered to be on the epiglottis. Only once it's visibly crossing, then it would be further down. So that's the epiglottis. So when we judge residue in the epiglottis, this is different from the oropharynx and the hypopharynx. For the epiglottis, and also for the vestibular vocal folds and subglottis, how do we judge residue? Coating. So now it is about coating or surface area. Hypopharynx, oropharynx, it wasn't. If we had coating in the pharynx, it might be a score of 1 to 3% or something like that. Here, if we have complete coating of mucosa, if the epiglottis is completely coated, it would be a score of 100%. This is because these aren't pockets anymore. So we're just making an estimation based off of surface area. So here we judge how much of the epiglottis is covered with residue. That if it's translucent, then you might still see the epiglottic tissue underneath it, but you're thinking about how much residue is on it or contacting it. So how covered is the epiglottis with residue? And so when you make the ratings for this, you're thinking about and conceptualizing both visualized and non-visualized surface area. But then you're rating only what you see in terms of residue. So if we looked at this image up here, we can see that we see maybe the top 2/3 of the epiglottis, but then you see, like, if we look down here, we still have all of this that's not actually being visualized up here, right? Some of it's hidden. So we have to understand that that anatomy is there. And so even if all of this was covered, and if all this blue was residue, then I'd probably give this honestly a rating of, 70% or something. If I thought I'm seeing 70% of the epiglottis, so then that's saying there's another 30% of the epiglottis that's there that I'm not seeing, but I don't know if there's residue there. I can't count it. So I'm going to say 70%, right? You can use multiple frames though when you're actually rating residue. So ideally we advance down, we would get that view. But if this is the entire view that we got, then all of this is covered. We don't know if there's any other residue, but we do know there's actually other epiglottic tissue there. So we would give it a rating of 70%. For the vestibule, we have our same boundary that we kind of talked about with the hypopharynx. So again, we are thinking about the shadow. What we're really thinking about is staying medial, not going on top at all. So going medial, then the vestibule includes this, what we call the interarytenoid tissue. So this is typically a slightly different color. It might have a slightly different textural appearance to it. And when we are abducted, we oftentimes see maybe a faint shadow, which kind of separates that tissue from the tissue above it, which would be the postcricoid tissue. I think most people would agree with those terms. So this would be interarytenoid, and then the tissue above it, I think most people would consider that what we call the postcricoid region.
So the interarytenoid space would be considered vestibule, but the postcricoid is the hypopharynx.
Exactly. Yeah, interarytenoid would be vestibule, postcricoid would be hypopharynx. So if I was to trace this, right, we're thinking about tracing the shadow, tracing it around. So there's some arytenoid that's part of the vestibule because the arytenoids extend down to the vocal processes, right? This is the inferior anterior-most aspect of the arytenoids. So arytenoids are part of the vestibule, but not all of them. So we would trace the shadow, and then I would kind of like then go here, trace this shadow, and then I also kind of see like this slight boundary, so then I would just kind of like try to trace that, right? So then that would be the boundary for the vestibule. Ideally, we would not be including this bolded line because that is actually, that is the boundary, so it'd be actually included in the hypopharynx, but not the vestibule, if that makes sense. And then not including the vocal folds. So then when we judge residue in the vestibule, we think how covered is the vestibule with residue? Now, this has not been stated anywhere, and again, I'm not sure if this is even completely accurate, but what I do is I typically think about this taking about 30% of the vestibule, the petiole being about 30%, this being about 30%, and the interarytenoid tissue being about 10%. That's a super, super rough estimate. I'm sure that's a way overestimate for the interarytenoid tissue, but when I'm trying to estimate, I kind of go in that type of thinking.
Can you say that again?
Yeah, so
That's 30.
yeah, so I kind of do like 30, 30, 30, 10.
Okay, got it.
You might even do like a third, a third, a third, and then the interarytenoid tissue is just like a super small amount, you know. But it's essentially thirds, and then like there's still a little bit there. Okay, so if we look at from this vantage point, we have this tracing, and I guess this is okay. I guess this is okay. I don't know. I'm actually like a little unsure, like if I would actually bring this dotted line down here, because I'm sure that if we abducted the vocal folds, that our view would change drastically. So if I could edit this figure, I would consider editing it to here. It would be much better judged during abduction. Because sometimes we can see residue kind of in this kind of little crevice here, and we're like, is that penetration or not? So then I would wait until abduction and be like, okay, is it in that interarytenoid tissue or not? So I wouldn't just base it off of here. We have our vocal folds. I think this is a little bit more self-explanatory, but the thing that we want to emphasize here that the vocal folds have height to them. They're three-dimensional. Oftentimes we get this view here where they just look like these two flat two-dimensional sheets, but there's height to them. Okay, so actually let me pull something up. Right, so this is from voice class. Are you saying that?
No,
Or
on the vocal fold, the right vocal fold.
that?
Yeah.
I think that's probably just a little, it's either sputum or it's the vocal fold process starting, they're like starting to kind of adduct a little bit and the vocal process is kind of jutting out.
Okay.
Yeah, that doesn't look like a lesion to me.
So the vocal folds are basically like a wedge of cheese.
The vocal folds are like a wedge of cheese. Yes, yeah, I can see that. I can see that.
Can you explain your thought?
Yes. So, like if you do a wedge of cheese like this.
Yeah.
So that's, you have your, what, you can look at it either way, but this would be your top, like what you see.
Oh, I see what you're saying. Oh, and then there's like a thing
And then
underneath.
this is like going into the subglottis. There's a dimension there to them.
Mhm.
That,
I just wasn't sure where you were going with it, but now I get it.
So yeah, so the vocal folds have height to them. So if we look at this kind of figure here, right? So this would be our vestibule, that's our epiglottis, our basic tongues over there. We have our ventricular folds here, the space between them. Then this would be our vocal folds, right? And so what we see on endoscopy is we look down and we see the top of the vocal folds, but then there's the medial edge and they actually kind of dip down, right? So these are all, that's all the vocal folds. What we see is the top surface, but there's a decent amount of height to them. They're a little bit longer than they are wide. There's a couple of other images. So here's like a dissected image again, right? So this is kind of the superior surface, and we can kind of see the vocal folds kind of entering, going down. Going down. I'm sure there's probably another couple images that I have. Yeah, going down. This is more showing the ventricles between them. But
So when we're looking at them from the superior view like that,
Yeah.
this, there's kind I'm not sure how to word it, but there's like a divot between the ventricular folds and
Yeah.
and we can't really see what's going on there.
Yeah,
I
and
never
here.
thought about, I never thought about the space there. 'cause
Yeah.
When you did the cross section,
Mm-hmm.
it goes back kind of far and you can't really see.
Yeah,
that.
exactly. So sometimes you can see it in patient. I mean, you can't see it going extending up completely, but some patients you have very maybe atrophic ventricular folds, that ventricle space becomes more prominent. And so this is what we're outlining in this figure are the different elements of what we consider to be the level of the vocal folds. And so for us, the level of vocal folds would include the ventricle, which means space. And so that's the space that's contained between the vocal folds and the ventricular folds. And because it's just space, if there's liquid there, it's probably sitting on the vocal folds. And so if we see stuff in that region, we consider to be at the level of the vocal folds. And so that space, the laryngeal ventricle, is what we see in this figure right here. It's this between the, these would be the ventricular folds. These would be the vocal folds, so it's the space between them. We see it, this would be a lateral view, and then this would be a coronal slice, histological slice, and we see that space kind of extending up. So there's a bunch of like little secretion glands and stuff in there, but it's a space where sometimes residue can hide. We can see that space much more prominently in here. We don't see it kind of extending up, but we see it kind of extending back. And so there we have it. So those are the vocal folds. So the level of the vocal folds for VASES, especially as it relates to rating vocal fold residue and MPIS scores, would include the ventricles, which we see here. It would include the superior surface of the vocal folds. What's highlighted here would be the membranous portion of the vocal folds. We have then the medial edge of the vocal folds highlighted here. So it's kind of the height of the vocal folds. And then it should also include, if there's something more posterior on the cartilaginous portion, should include that as well. So all of that is the boundary for the vocal folds. When we think about the lowest aspect of the vocal folds, which is what separates penetration from aspiration, we think about the lowest, the inferior most boundary of the vocal fold is what we call kind of like the lower lip. Sometimes we lose what it would look like on the anterior commissure. So what I do is I think about extending this line here, extending this line here, thinking about where would they meet. And so it would be about right there. So if we see stuff in this region, I want to highlight this. If we see stuff in this region, we are calling that penetration. We are not calling that aspiration. And that definitely, I think, is different than what many clinicians do. And personally, feel pretty strongly that it should be considered penetration, because I think it tells us the same thing about potentially swallowing physiology. It's the same thing in terms of sensory innervation. Like we would not expect any sort of cough response if there was stuff right there. It's in the vocal folds have height to them. So, you know, to say something here is penetration, even though the vocal folds are clearly extending much further down, it doesn't make sense. So for VASES, that's what we chose to do. The other thing I'd like to make note of in terms of rating vocal fold residue is, I think what we lean towards doing, we didn't specify this in the manuscript, is we judge residue, the amount of residue present relative to the superior surface of the vocal folds. And that's because we don't always get a really great image the entire time of the medial edge. So if this entire blue shaded region up here on the top right was covered, then we would say 100% of the vocal folds are covered. If only this blue shaded region, only the medial edge was covered, we would probably say around 100%. If we have all of this space covered, we might have 200%, right? Because this would be on top of the vocal folds, plus this is on top of the vocal folds. And we're judging things relative to just that superior surface. So technically, vocal fold residue could probably range from 0 to 200%-ish. Maybe a little bit more if we're thinking about the cartilaginous portion as well. We don't see that often at all, but
I've never seen like 200.
no, and I'll say that, as I kind of mentioned before, the idea is that VASES will kind of develop and kind of evolve over time. And when we did the original manuscript, we used a visual analog scale, which was bounded by 0 and 100. And now it would appear as though we could just provide a number and say 100 or 200 or something, right? And so now we're not bounded by 100 anymore. And so to answer your question, have I ever seen that? It's a little difficult for me to say because we previously only rated using the visual analog scale, and I'm sure it's happened before and we just didn't account for it. Okay, so then we get to the subglottis. So this will include everything below that inferior most point, which we see here. We have kind of 3 anatomic landmarks within the subglottis. We have the subglottic shelf, which is the triangle extending up to the cricoid cartilage. We have that first ridge. That first ridge for most people is the cricoid cartilage. It's possible that sometimes the cricoid cartilage is a bit more hidden, and that's actually the first tracheal ring, but most of the time it's the cricoid cartilage. So whatever it is that you're seeing, we're considering it the cricoid cartilage, but that could be wrong sometimes. And then everything below it would be the trachea. So when we rate subglottic residue, we rate it relative to the subglottic shelf, just like vocal folds is relative to the superior surface, just like oropharynx is relative to vallecula and hypopharynx is relative to piriforms. So this is relative to the subglottic shelf, meaning that if the entire subglottic shelf was covered, we would have 100%. If the entire subglottic shelf was covered and we had stuff in the trachea, then it would be more than 100%. Again, this was not specified in the original manuscript because we were bounded by 0 to 100, but theoretically with numerical ratings now, that could be the case. If we had nothing in the subglottic shelf, but we saw a little bit of stuff in the trachea, we would pretend to move it into the subglottic shelf and estimate how much covering would there actually be. So if there was just like a little dot back in the trachea, we'd move it to the subglottic shelf and say, I don't know, 3% of the subglottic shelf is covered with residue. Okay, so questions about any of these anatomic boundaries? When we look at a video clip, we would provide these ratings here. Bless you. So we use these boundaries to define residue ratings. We would also use the boundaries to define the bolus location at swallow onset during the swallow, right? So to know that, we need to review the temporal boundaries, but again, we're thinking at the onset of during the swallow, which location is it in? And we're really thinking from, yeah, I guess just which location is it in? I would think it would go from height. It would go from oral pharynx to epiglottis to hypopharynx. And then if it's entering the vestibule vocal fold subglottis, you would make note of that. Okay, so then the last thing I want to review and really kind of ingrain in us are the temporal boundaries. And I think that this is the thing that might be the most challenging, but it's also not something that we measure like, it's not like a rating, like you're not entering a frame number. So you don't have to be overly concerned with it, but you should be having an understanding of what they are theoretically, and then using that to guide a lot of these judgments. So you mentioned that we have 4 boundaries: before, during, after, and between Bolus trials. How do we creates the boundary for before the swallow? What defines that?
It starts at like ideally when the bolus enters the mouth. Or
Yes.
the beginning of this video, but like it's kind of depending, but like ideally when it enters the mouth, and then it ends when you start to see like pharyngeal constriction.
Exactly. Almost exactly. Yes. So it begins, theoretically, it should begin when the bolus is being dispensed into the mouth. We don't see that on fees. We don't see the oral cavity on fees. So that definition should influence how you're actually recording and performing your fees. So what I do, I didn't do this until like a year before I left UCSF, because laryngologist I was working with actually did it and showed me. I was like, oh, this is so brilliant. I feel like what's so often done in clinical practice is you do a fees and then just let that fees run for 20 minutes.
You have no idea what you feel like.
And you can't, like, you have no idea, you can't really find the swallow. You're like, where was that really cool swallow I wanted to find? And you like just have to like scroll through 20 minutes of video. It's very annoying. So what you can do, at least in all the equipment I've worked with, is you can stop and start the recording, and that'll create a new video clip. So maybe you present someone with a patient per volume of cup sip liquid, natural, non-Q, non-held. Take a sip, drink it like you normally would. They do it, you turn the video clip off and then immediately back on. So we don't want to like lose any visualization time, keep it running, but splice it in real time. So then you create a new video clip for this Bolus trial. Then you create a new video clip for this Bolus trial. So that is one way to make an inference of before the swallow. That's kind of the onset. So that might influence how you actually perform the fees, is creating these new video clips. The other thing is a clinician announcement. So the clinician announcing the bolus as it's being dispensed into their mouth. And so those are the two cues for the videos that we'll be doing here. That's the onset of before the swallow. And then it ends at the beginning of during the swallow. So the beginning of during the swallow is kind of what we consider as an estimate of pharyngeal swallow initiation. And so that's defined as the onset of pharyngeal and or laryngeal elevation and pharyngeal elevation plus or minus some contraction that's uninterrupted leading to the swallow. Contained within the during the swallow phase is oftentimes endoscopic whiteout. For most people, most of the time. Super severe people who have very little pharyngeal constriction might not have endoscopic whiteout. But within the during the swallow phase is endoscopic whiteout. Most of the time, we are seeing a few frames before endoscopic whiteout and a few frames after endoscopic whiteout. That's still considered to be quote unquote during the swallow. So it's really the onset of laryngeal and pharyngeal elevation that's uninterrupted and leading to the swallow. Pharyngeal constriction can get a little hairy because sometimes people can start to constrict and then it kind of relaxes again and then it kind of constricts again. And it's a little bit more kind of preparatory. And so what I'm really kind of looking at here oftentimes is really that post-cricoid interrytenoid tissue area and seeing when is that starting to kind of looking like it's lifting towards the camera in an uninterrupted fashion. And then it ends when that same kind of intrarytenoid post-cricoid region gets to its lowest resting position. The very first moment it gets there. It might get there and then the pharynx kind of keeps relaxing and is becoming more unconstricted, but it's returned to its lowest resting position. We've used that definition because that's what's used in video fluoroscopy research, especially using the aspect method by Dr. Katrina Steele, some work by Dr. Sonia Malfenter. So that's the end of quote unquote during the swallow, and it's the beginning of the after the swallow phase. So what are the boundaries now for quote unquote after the swallow? 5 seconds of inactivity, rest breathing, something like that, sure.
Vocalization.
Vocalization, sure.
Advancing the scope.
And advancing the scope. What about a cough? That would be like an airway protective reflex. So that would, let's say someone aspirated during the swallow, they breathe for 2 seconds and they give us a little throat clear or cough, that's not a signal now for the new temporal boundary. That's now an airway protective reflex that's contained within the during the swallow phase. So we're really waiting for actual vocalization, not like a airway protective reflex. So E, or them starting to talk, or something. So it's vocalization, but not necessarily like a cough or a throat clear. It's the 5 seconds of inactivity. That would be ideal. That I think should be your protocol. That's definitely my protocol. So waiting for 5 seconds of rest. And then once that's done, then either asking someone to talk or advancing the scope. And then the between bolus trials is then from that point on to the next before the bolus, before the swallow. So when do we judge residue? After the swallow is when we're trying to capture residue. Can we judge residue between bolus trials? Sure. Is there anything else you want to add to that? There's something I'd like you to add to that.
I normally presume when you say, oh, interesting, that you mean.
No, that is right, but I would love a little bit of elaboration. There's a little caveat. Yeah.
Unless they swallow again, right?
Yeah, I mean, they can even swallow again. It's just, we're trying to capture what's present after the swallow, but oftentimes we get much better views between bolus trials, especially if we're advancing the scope or trying to look subglottically. I don't really advance the scope much anymore, but you can. And so as long as it doesn't appear as though things have changed or it doesn't look like bolus is flowing from one location to another or something, then you can do after the swallow.
Wait, so to clarify, it's better to do it in between swallows or after swallow?
So you want to try to capture what's present after the swallow. So that's why the 5 seconds of inactivity is so important, right? So you're just kind of like resting there, they're breathing, you're getting 5 seconds. Hopefully you're getting a very good view and that's good. But it might not be good enough, especially if there was only 1 second of breathing, we started to advance the scope, right? And so then we take what we can get, and we might be judging between bolus trials. But if, let's say, as you're advancing the scope, you notice a lot of stuff spilling from the oropharynx into the hypopharynx, you want to try to think about what that was in the oropharynx and not have it in hypopharynx, right? Or if you are advancing the scope and there's stuff in the vocal folds and you wait there and eventually drips down to the subglottis, you want to say, no, this was like after the swallow, it was actually at the vocal fold. I just waited a little bit longer and eventually dripped down, right? That would be a change in your PAS rating potentially, but not in terms of your residue rating. So you want to try to, your rating should be representative. That's probably a good way to say it. Your rating should be representative of what was present after the swallow. But you can take into account what you're seeing between bolus trials if you're like moving around and you're like, oh yeah, I can see this a little bit better now.
Nothing like dramatic.
Yeah, but if nothing, and so that's, as you advance the scope, sometimes people might start to swallow again. And just because they swallowed again, we don't necessarily get a big change in residue rating. So even if they swallow again, don't necessarily panic unless you're like, this does seem a little different. So let me like try to do my best and see what was present beforehand. So it should be representative after the swallow. But that's why we have PAS ratings for cross bolus trials, because you could wait there and we would probably want to capture, yeah, if we waited long enough, it spilled. And that's why we were like, oh, well, then that's why between bolus trials, it moved from a 5 to a 7 or 8 or 6, something like that. Okay. So that is our review of our anatomic and temporal boundaries and how to rate.